Good afternoon and welcome to the Scifest Africa webinar on gaining public trust for anti-COVID-19 vaccines. I'm your host, Stephen Lang. The race to reach herd immunity continues worldwide. The prolonged COVID-19 pandemic has adversely affected the social and economic standing of many nations, and South Africa is no exception. While vaccines are an essential element of the fight against the pandemic, the reality remains that the successful administration and rollout of COVID-19 vaccines is largely dependent on gaining the public trust of government, science, and related institutions. This is the essence of what we're going to be talking about. Let me briefly introduce the members of our panel. Professor Shabir Mahdi is Professor of Vaccinology at Wits University. We were going to be joined by Ms. Wendy Ovens, who is the Managing Director of Healthcare at non-profit organization Right to Care Health Services, but due to family commitments, she is not able to join us. Mr. Kamusi Mutoti is a Deputy Director of Biological Medicines at the South African Health Products Regulatory Authority, SAPRA. And Dr. Amit Mehto, who is a medical doctor and vaccine rollout lead at Pauri Garhwal district in India. Welcome to the panel. I will direct questions to each member in turn, and then other members of the panel can chip in. At the end of the discussion, viewers and members of the public will have an opportunity to ask their own questions. Please use the Q&A function to send in your questions. And let's not waste any time and begin now with Professor Shabir Mahdi, who is a professor of vaccinology at Wits. We've heard that the current level of people who are fully vaccinated in South Africa is 21.5%. I checked this yesterday. Experts say that this is not high enough, but it's not high enough for what? The answer we hear most often is that it is not high enough for herd immunity. Should herd immunity be the benchmark? And what does this term actually mean? Professor Mahdi?
We need to clarify, which obviously speaks to the issue as to what is the main goal behind vaccination. So when we suggest that we're trying to aspire to herd immunity, in a way, what it really infers is that we're trying to get to a stage where there's very limited and very little opportunity for the virus to continue transmitting in the community and to spread between people. So you're going towards a state of the possibility of being able to eliminate the virus. Now, when it comes to SARS-CoV-2, it's no different to many other respiratory viruses and pathogens that circulate. And in that, in the history of mankind, we've never been successful in being able to eliminate the respiratory virus. And I don't think SARS-CoV-2 is going to be any different. So I think we need to move away from the concept of herd immunity. And the issue that we need, or the theme that we need to be discussing, is what sort of threshold is required to de-risk the ability of the virus to cause large number of cases of severe disease and death. So herd immunity, irrespective of whether we get 50 or 80% of the population vaccinated, we're not going to get to herd immunity. Certainly not for the current generation of vaccines. And experience from many high-income countries, which have now been able to vaccinate close to 80 to 85% of the population, basically indicates that they haven't been able to achieve herd immunity. So no, we're not going to get to herd immunity, and we need to learn to live with the virus. But what we are able to achieve with vaccines, which is the primary goal of vaccines, is the prevention of severe disease and death, which doesn't mean that vaccines don't reduce infection and don't reduce transmission. Vaccines do reduce infections and transmission, but much less effectively compared with how well they perform in protecting against severe disease and death. And that speaks to the issue as to what to make of the number of 25% or 21% of South Africans being fully vaccinated. It's not about the number of people that are vaccinated that's of importance to South Africa in the immediate term before we experience another resurgence. It's about who is being vaccinated. And the primary goal of vaccination in the immediate future is to ensure that at least 90% of people, especially those above the age of 50, and anyone with an underlying medical condition, are completely vaccinated. And if we're able to achieve that, we would be able to go into a state where we would be able to reopen society, get back to a relatively normal lifestyle, not because the virus will have disappeared, but because we've got a certainty that the vast majority of people that are most likely to end up in hospital and that are most likely to die are now being protected against that.
Thank you very much. Would any of the other panelists like to add to that? No? Can I put the next question to Mr. Kamusi Mutoti? We are obviously very concerned about the regulation of these vaccines. There have been concerns expressed about the fact that they were approved so quickly and that there were so many different vaccines. Could you just take us through how SAPRA actually tracks and monitors the safety of these vaccines?
Thank you, Stephen, for that question. And indeed, as SAPRA's legislative mandate, SAPRA responsibilities to monitor, like you've indicated, and to evaluate and to register these medications in the country. And that will also include inspection of the specific sites that are performing the clinical trials and also manufacturing. And how do we monitor safety? And then safety is monitored throughout the process. And this is through monitoring and authorization of clinical trials, where the clinical trials are being conducted for the purpose of establishing the safety of the vaccines. And once the safety of the vaccines has been established through the clinical trials, the manufacturer will eventually submit an information, what we classify as an application or the dossier that would have been packaged in terms of our requirements. And what we'll do throughout the application, we'll also do an assessment of the scientific information data that has been submitted to demonstrate that indeed the product or the vaccine is safe. And that's the responsibility of the regulator. Even when the product has been authorized for use in the country, the South African Health Product Regulatory Authority will also continue to monitor the safety of the product, even after the product has been registered, it's in use. And this is through what we classify as a post-marketing or post-registration vigilant activities, wherein all the reported cases and adverse events, the SAPRA will continue to investigate and monitor the safety profile of the product that is being used in the country. And that is the responsibilities of the regulator, to monitor the safety of the product from all phases, whether a preclinical phase 1, phase 2, phase 3, and also after the phase 4 when the product is being used in the country. And that's the responsibilities that has been written down into the relevant Act 101 of 1965, Stephen. And I think some of the concepts that I'm highlighting, Professor Maidi has already highlighted on them. So that's what we do as the regulatory authority, Stephen. Thank you.
That's very interesting. Do you also use these so-called vaccination passports as a way of monitoring the after effects of the vaccine?
Currently, what I can highlight, Stephen, is that, and I think this is from part of the legislative mandate, as I've already highlighted. We are required by the relevant legislatures in the Act that we must continuously monitor the product once it has been administered into the different communities on the patients, and we follow the adverse events following immunizations. And we, as the regulatory authority, we have made relevant platform for the public and the communities. This includes the healthcare professionals and also the manufacturers to share with us all other adverse events that are associated with the immunizations. And as you are aware that the National Department of Health, they've introduced the vaccination tracking system, wherein after vaccinations you're able to it's able to allocate the relevant number in terms of the vaccinations. But currently, through our Made Safety app and all other channels that we have made available, you are able to monitor and track all the other safety concerns that has been reported, Stephen.
Thank you very much. Dr. Meadow,
Mhm.
where cultural and religious beliefs contradict evidence by science,
Mhm.
and I'm sure that in India you must have different cultural beliefs, obviously, to the ones here.
Mhm.
How have you dealt with engaging with the public to ensure that you're still sensitive to the cultural beliefs, the religious beliefs, but at the same time, you're encouraging more people to take the vaccine?
That's a great question, Stephen, because that has been one of the most difficult things to deal with, because as and when the vaccine rollout started to happen, the first concern of everybody, including some of the health workers who were supposed to get the vaccines in the first place, was that is it safe enough? And does it have some side effects which the scientific community might not know as of yet? And there are different views. So on the outset, I think I would say that the first approach to problems like these should be that every community, every person should be considered as a human, and the value should be respected before really, or rather instead slapping on the scientific evidence in their faces. The thing that really helped us as a team at the hospital where I was working and leading the vaccine rollout was to use the health belief model, which really breaks down the concerns of people into several different parts, which are amenable to solution. For example, a person might have different concerns, but they could be broadly categorized as, let's say, their perceived susceptibility, perceived barriers to action, cues to action. So, for example, the first concern of people could be, am I susceptible to the disease? Perceived susceptibility, that is. And then we can work through these individual parts and sort of design the health communication in a way that appeals to their values more, rather than having a one size fit all. Then another part of this framework, this health belief model that we used, was perceived severity. So, for example, if a person believes that the severity of the disease is not going to be very high, then they would rather say that, okay, maybe I'm better off without the vaccine. So the messages which we use in our health communication campaigns were tailored and broken down into these parts. And also, we always kept in mind that the message should be in a language or in a format that's understandable to them. Also, it always helps when the message comes from a person who is in a sort of authority, as in a community leader or religious leader. So yeah, that always helps. So using the health belief model and using channels of communication that the people would use, and in a way that the form of communication that is acceptable to them, really helped us. Also, what we did was on the first day of the vaccination, the director of the institute, the dean, they went ahead for the vaccination. So when the public knew that, the leaders are getting the vaccination, then maybe it's safe. So it's basically a combination of multiple efforts and using this framework that really helped us succeed in our vaccine rollout.
Thank you. Let me ask our South African experts, Professor Mati and Mr. Mutoti, if there are parallels here in South Africa. Would you say that the cultural and religious reluctance to take vaccines is similar in South Africa, or would it be different to what Dr. Meto has said?
Thanks, Stephen. So I think that we do share some similarities in that there are cultural, religious influences. But at the same time, I think these are very different societies, and to be able to unpack the reasons why people are either hesitant or apathetic when it comes to vaccine, and that is very different from someone being anti-vaccination. It's multi-layered in terms of the contributing factors. In the South African context, I do believe that unfortunately we have lacked role models championing the case for vaccination. Be it amongst religious leaders, politicians, be it amongst sporting personalities, or even entertainment personalities. We haven't seen a rush of people coming forward, of high-profile people coming forward to champion the case of vaccine. In fact, on the other hand, even amongst politicians, with the recent local elections that we went through, there was almost no mention of vaccines in the context of the elections itself. And in fact, politicians were stepping back rather than advocating for fear of sort of marginalizing a group of people that might otherwise not be pro-vaccination. So I think it's complex. In South Africa, I believe that it's a combination. The anti-vaxxer lobby is a very vocal lobby. They obviously create a huge amount of havoc when it comes to social media and spread of misinformation. But I think it's more, I think the big drivers behind the relatively modest uptake of vaccines in the South African context is a combination of apathy, which Amit sort of made mention of, in that some people really believe that because they're not at high risk of developing severe disease, there's very little reason for them to be vaccinated. And those will be a large majority of people under the age of 40, as an example. Without really understanding that them being unvaccinated still poses a risk to other individuals in society with whom they might come into contact, and they could be responsible for the spread of the virus. So the apathy part of it is the one part. The hesitancy part is also important, and it speaks to the earlier question that you raised. And many people are skeptical about the safety of vaccines in that we don't have long-term safety data. And that is true. And that these vaccines have been rushed, which is not really true. The reason why we've been able to condense the period of time of developing vaccines from 10.5 years to 10.5 months is not because of shortcuts being taken, but because of the tremendous amount of financial as well as scientific resource and leveraging on past technologies and past experiences that has enabled for us to develop vaccines in a short period of time. Because if it took the average 10.5 years to develop a COVID-19 vaccine, we wouldn't need a COVID-19 vaccine, because a large majority of people would derive immunity through natural infection. So the hesitancy part, unfortunately, to some extent, is coupled to the misinformation that's spread by the anti-vaxxers. And I think when it comes to the safety of vaccines, we've got in South Africa, as an example, before a child turns 5 years of age, that child would probably have received close on to 30 different vaccines, 30 different doses of vaccine or types of vaccines. They receive vaccines at 6 weeks, 10 weeks, and 14 weeks, and at 9 months, at 18 months, with a number of different vaccines being given at a single point in time. Now, when those vaccines were licensed, we also didn't know whether those vaccines were going to be harmful 10, 15 years later. And the short answer is, with all vaccines that are licensed for use, the side effects of vaccines are most likely to occur in the immediate period after vaccination, in the 2 to 3 week period after vaccination, and exceptionally maybe 2 to 3 months later. Because that is the time when the body is mounting an immune response to the vaccine, and that's the immune response to the vaccine is what would usually induce a side effect. So you don't get you don't get side effects that unmask years and decades after a person has been vaccinated. So yes, we don't have long-term data on the safety of the vaccines, but that's simply because we don't actually require that long-term data. Because almost all of the side effects that do occur from vaccination are side effects that are strongly temporarily related to the time when vaccines are given and occur within a 2 to 3 week period after vaccination.
Okay, so what I'm hearing from the beginning of your response is that, to a large degree, the message hasn't been carried forward effectively. There hasn't been a sufficient publicity campaign. You said that there weren't enough leaders demonstrating how they were taking the vaccines, and sports personalities, etc. So this speaks to a marketing campaign that is a problem. Mr. Mutoti, can I ask you, do you feel the same way? Perhaps you disagree with Professor Mahdi, or perhaps somebody has dropped the ball and hasn't done the marketing properly. What's your take on that? Your microphone, Mr. Mutoti.
Thank you, Stephen. And I agree with Professor Mahdi, I think 110%, that in fact, the information and communication, and I think from all the institutions in the country, we have not necessarily been conveying the message about vaccination. And as the South African Health Product Regulatory Authority, I think through our CEO, we have made it known. And if you can visit our website, on different webinars and platforms that are available, we'll always join those platforms to make it known to the community that the products that the South African Health Product Regulatory Authority has made available is because we are confident of the safety and the efficacy and the quality of this product that are being used. And this is the message that should be carried across as we acknowledge the cultural diversity and the religious beliefs that we have in the rainbow nation, with these beautiful countries of ours. And indeed, we all need to take responsibilities for promoting vaccination, as Professor Madi has already highlighted, that the product that we brought into the country are of good quality and they are safe, and we're confident of the efficacy. And all we need to do is to just share this information. And as for the anti-vaccination group or lobby, and again, this is because of the lack of the relevant necessary scientific information, that again, this should also be shared with those groups by all the research institutions, including the department and the politicians and us as a regulator, so that we are on this together and with the relevant understanding. Thanks, Stephen.
Thank you so much. Dr. Mehta, how do you feel about the way the vaccine has been publicized, the incentives that people have been given? What do you feel about that?
I think the incentives to get vaccinated is it's pretty much the same as has been with the other vaccines. But I would like to go back a little bit with what Professor Madi said a little while ago, that the social media really creates a havoc. So on one end, us as a scientific community, I mean, Scifest Africa, what we're trying to do is to circulate the scientific evidence in the best possible palatable way for the community to accept the vaccines. But at the same time, we live in a day and age where information is as prevalent as disinformation, where, and it's usually that the disinformation that carries fire faster. I mean, and that is a really a force which is resisting the spread of scientific information. That, as for example, Professor Madi said that the vaccines are safe. There are not really any side effects in the 2-3 weeks window. And me personally, when I was going to take the vaccine, as a person, I did read the research, whatever was available at that point, and I found that there have been no side effect. Nothing to be concerned about, I mean, other than fever and just a bit of body ache, which is pretty common and which is to be acceptable as well at the same time. But the social media, the havoc that it creates is something that should be really aimed at, as in the disinformation should be battled with disinformation at the same time. Disinformation should be battled with information at the same time. So yeah, that's my take on that.
Let me put a question to the panel as a whole. What's confusing for me as a layperson is, why are there so many different types of vaccines? Surely they can't all be the same. So if they're not the same, then one must be better than the other. And why can't we only have the best one?
Yeah, well, I think that's a really good question. And obviously, the reason why we need multiple vaccines, firstly, is that usually the history of vaccines to start off with, it's only about 10% of vaccines that start off in a laboratory and that go into human trials are eventually licensed. So to start off with, there's a very high failure rate. With COVID-19, it's been more of an exception rather than a rule. In terms of the number of vaccines that were successful, there have been a few vaccines that have failed in clinical trials. Now, the other big issue that we face is that right at the start of the development of these vaccines, we didn't know which technology was going to be best suited to develop a COVID-19 vaccine. So we had 4 different types of technologies, 2 that were sort of tried and tested in the past with other vaccines, and 2 relatively new technologies, at least in the field of vaccinology, that were being experimented with. And as it transpired, out of the 4 technologies, all 4 of the technologies have been able to yield vaccines that are actually effective. But you are correct, the vaccines do differ. So we shouldn't think of COVID-19 vaccines as a single entity. These vaccines do differ. Where they do converge is how well they protect against severe disease. So across all of these vaccines, when it comes to protecting against death and against hospitalization, your effectiveness of these vaccines is in the region of 80 to 90% against hospitalization and 90 to 100% against death, or not 100%, 90 to 95% against death. So they converge when it comes to how well they protect against severe disease. But when it comes to how well they work in protecting against infection and mild COVID, then there's huge divergence, anything from 50% to up to 90%. Now, why do we need to have multiple vaccines, knowing that there are some vaccines that are going to perform better than other vaccines? The reality is what we're facing currently, despite having 22 different vaccines that are currently authorized for use in one or other country, 22 different vaccines. Despite that, less than 4% of the population in low-income countries are vaccinated. The average, global average is 50%. High-income countries, about 80% of the population have been vaccinated. In low-income countries, less than 5% of the population. And most of those low-income countries are on the African continent. The reason for that is that it's not within the ability of any manufacturer, single manufacturer, to meet the demands at a global level in terms of the quantity of vaccines that are required. When they build manufacturing facilities, if they build manufacturing facilities with a long-term view, not just to provide COVID-19 vaccines in the immediate future. So they're not going to invest in building facilities that will be able to churn out 5 billion doses of vaccine in a year, knowing that 1 year later, they're going to need to cut back the production to 500,000 doses rather than 5 billion doses. So we need multiple players. It was de-risking the program by funding multiple players to actually produce vaccines, not knowing who was going to be successful. As it transpired, we were spectacularly successful. Very few vaccines failed. But despite having multiple players, we still pressed in terms of ensuring equitable access to vaccines, and especially for low middle income countries. So having a single manufacturer was never going to be an option. And even with multiple manufacturers, we still face problems. But you are correct. We need to understand that not all COVID-19 vaccines are equal. However much we would love them to be equal, they're not equal. We can have different expectations, but most important, if our focus and if our goal is a protection against severe disease and death, then all of these vaccines start converging in terms of how well they protect against severe disease and death.
Mr. Mutoti, would you like to add to that?
Thank you, Stephen. And I think Professor Madi has well covered that question. And indeed, as the regulator, our role is to promote access to health products. And irrespective of how many applications are being submitted to the regulator for review, we'll review all of them because our role is to promote access. The more products available, the more people will be vaccinated, and therefore, the more people are protected against the COVID-19. So that's our role, Stephen. And thank you again.
You talk about access. That's interesting because it seems from the stats that I'm reading that people in urban centers have better access to vaccinations than people in rural areas. Now, why is this? Are we not distributing the vaccines properly, or are we not getting the message out to the rural areas better? Mr. Mutoti, I think that comes back to you.
Thank you, Stephen. And indeed, as the question says, the urban and the rural. But as the regulator, our understanding is that all the vaccines that we have authorized in terms of logistical transportation that looks at the temperature monitoring of the product, our understanding is that through the National Department of Health, all the vaccines have been distributed to even the rural areas where product would have to be monitored for vaccination into the different communities. Our understanding is that I think what I've been following in a few of the what we call mostly rural provinces, I think in the Eastern Cape and also in Limpopo, which is mostly rural, we've just learned recently that they are doing well in terms of vaccination. I think they are even beating mostly what we refer to as the suburb provinces. So that's our understanding. So you could say, therefore, the distribution of vaccines, it's properly being done in terms of the bringing it to the community.
Thank you. That's good. That's good news. I'm in the Eastern Cape, so I'm happy to hear that. Dr. Mehta, have you noticed also in India that there's a discrepancy between accessibility in rural areas and urban areas?
Yes, I would definitely like to add to that what Professor Mahdi and Mr. Mutoti already mentioned. What I observed during the vaccine rollout and in the months that ensued was that the primary reason, or I should say the reason is twofold actually. One, because of the health system capacity at the rural area to be able to procure the vaccine, to deliver the vaccine, the staffing. But then another side of the problem of slightly lower coverage in the rural area, although I wouldn't say that it was the discrepancy was quite a lot, but still being there. So the other reason was that in the rural areas, people are usually less literate as compared to the urban areas, and they're easily swayed by what I already mentioned, the havoc of the social media. And they're also easily swayed by the community wave of resistance to the vaccine. As an example, if one of the community leaders or their neighbors are not taking the vaccine, then they sort of follow the pattern. And that is compounded by, as I already mentioned, the health system weakness, so to speak. But I would like to point out that India made like a good effort in sort of balancing these things out in terms of accountability and feedback in terms of how the vaccine rollout is performing in the rural areas. The place where I was working was a district headquarter, but we were having these dashboards and regular visits to the villages. Some of them I did personally, where I would observe the whole framework or the whole delivery system, and also how it is performing in terms of what the population is there of the village and how many of them have actually got the vaccine and what the problems are. I mean, although there are some access problems there, but nothing that cannot be dealt with. And I think to know the problems, as in the health system weakness and the effect of lower levels of literacy and social media, it really helps to sort of curb them down.
Thank you. I think what you mentioned about social media is true in South Africa as well, that there is very widespread social media, but still the biggest media platform in the country is radio, and particularly into the far-flung rural areas where it's sometimes difficult to get messages out. Radio is still, especially in indigenous languages, radio is extensively used, and perhaps that can be considered as well. But coming back to this issue of trust, whether people take or decide to take or don't take a vaccination depends on trust, because the government has largely been putting out the message that people need to take the vaccine. But there's also the aspect that there's been a lot of corruption in government. In certain departments, there have been tenderpreneurs, and PPE equipment has gone missing and used for funny purposes, etc. So that undermines the trust. And at the same time, it's also required to trust science. And you are all scientists, and it's important to trust science, but at the same time, we're often getting conflicting messages, like conflicting messages about whether we should have a third shot, whether we need a booster shot. So the messages are not always consistent, which I think undermines trust. I'd like you guys to speak about trust. Professor Mahdi, how would you like to talk about it? Do you think that the relevant institutions are trusted sufficiently?
No, I mean, I think in the South African context, there's a huge amount of mistrust between society and government. And in fact, that is very much the genesis of many of our problems, including when it comes to the trust that society has on what government requests it to do. And as you mentioned, that trust has been lost because of the debacles that have surrounded something such as PPE procurement. So that mistrust does exist. I think there was a survey, in fact, that was done in South Africa, which indicated that the people that the communities were most likely to trust were, in fact, healthcare workers. But that also brings up another issue in that that sort of trust because is sort of cast into doubt when you have amongst the healthcare fraternity single individuals standing up and speaking to a topic which they simply don't have any expertise in. And in South Africa, we've had the misfortune of needing to deal with cardiologists and sport physiologists making bold pronouncement about what COVID is and what COVID is not, and what vaccines are and vaccines are not. And that creates, unfortunately, a lot of confusion in the community. And I think we're South Africa, and this is a government issue, and it's a regulatory issue, not SAPRA, but it is a Health Professional Council regulatory issue, in that they're not prepared to stand up and take on those individuals, which sort of perpetuates a sort of uncertainty in the community when you have the Health Professional Council in South Africa, as an example, not making a clear start and not taking action against those individuals, the healthcare practitioners that are spreading misinformation. So again, a really complex issue, but without any doubt, I think the South African government hasn't done itself any favors in terms of ensuring that they gain the trust of the community because of how poorly it's dealt with issues surrounding corruption, including in the context of COVID-19.
Mr. Mutoti, I think you want to say something onto that.
Yes, indeed, Stephen, and indeed, thanks, Professor Madi, for highlighting those issues. And then I think if I make a reference to South African Health Product Regulatory Authority, as you're aware, some years back, we were housed as the National Department of Health. And ever since the promulgation into SAPRA, what we have done is to make SAPRA accessible so that the community and the people of South Africa are aware of the legislative mandate of SAPRA. And that's even today, we can assure confidence to the community that the regulator perform its function without fear or favor, and that we may not be influenced by anyone, including the president or the ministers, when we do our job, because the responsibilities that is assigned to us is of protecting the public and making sure that the products that are available are of good quality, the product is safe and effective. And I think Professor Madi has already highlighted that. And as a South African Health Product Regulatory Authority, we always go out and share the relevant scientific information so that the public can have confidence in what we do, because we do that, like I said, without fear or favor. And we are a science-based regulatory authority, and we take decisions that is informed by science only. And we don't take any decision that is influenced by either politics or what is economically happening around the globe. But this is our responsibility in terms of the relevant Act 101 of 1965. And indeed, all the government structures across all the spheres, there's a need for us to start building confidence so that the communities and the population can have confidence on what we do as the public servant. Thank you, Stephen.
Thank you. Dr. Mehta, your take on trust?
Okay. I think that trust in this context really applies to trust in the government, and that has a lot to do with the political leadership. In my experience in India, I think the message was so strong and so superfluous, as in we already have, fortunately, if I may speak, right now, a very strong political leadership that people would say, okay, if this government is doing something, it's probably for the better. But I do agree that trust is not like a single issue. It's a very complex issue, and it works differently at different levels. And I've experienced, for example, my workplace, the place where I was living, or other places where my friends were working, my colleagues were working. It was not definitely like a problem which was solved just by a strong political leadership, although it did help. The trust was also at regional levels, as in if they had a case of an adverse reaction, or it might be highlighted in a negative way, then the trust really fell down. So I think to deal with the trust issues with regards to the safety and the efficacy of the vaccine, it should start from a strong political leadership at the national level, but then the administrators and the field workers, so to speak, have to deal with the nuances and the problems at their level, on a case-by-case basis and personally. Yeah.
Thank you. Yes, Mr. Mutoti, you want to add something to that?
Yes, thank you, Stephen. Probably just an additional point that I think for all government institutions and all the private sectors, also within South Africa, and probably this will apply globally. There's a need for strict measures to be taken against people who ascend these public platforms to address the issues that are not really expertise on them, especially when you're talking issues of the vaccinations. These are issues that should be addressed by the experts, people who are really informed on what vaccines are, how vaccines are developed, and what is vaccinology, versus people who are saying the public stage and say so much about vaccines when they are not really so knowledgeable about that specific subject. So that's something that needs to be done, and all the other regulatory authorities and council that regulate different professionals should also take this into consideration and start taking serious measures against those who goes and ascend public spaces and talk about subjects that requires experts to address. Thanks, Stephen.
Thank you. It's interesting. We're talking now about trust as an incentive to get vaccinated. And we can also think about it. Are we going to use a stick or a carrot approach to this whole thing? Are we going to say, take the vaccine because it's a good thing, it will save your life? Or are we going to say, use a stick and say, don't take the vaccine and you can continue working? And I've heard cases where some companies have offered leave days to employees who agree to take the vaccine. Some have actually given cash bonuses to their employees, which seems like a little strange to me, but it is quite interesting. And in other cases where I'm at Rhodes University here, they've said, if you want to come onto campus next year, you need to have a vaccine. So that's laying down the law quite harshly. How do you balance this stick and carrot approach? Some ideas on this.
Yeah, so Stephen, like everything else in life, your choice comes with consequences. If you choose to be vaccinated, the consequence of that is you're protecting yourself against severe disease and death. If you choose to be unvaccinated, it comes with consequences. What you can't expect is to choose to be unvaccinated, but then expect the rest of society to bear the burden of your choice. And what I'm referring to is when there are limitations that are placed on an individual that chooses not to be restricted, those are the consequences of that particular choice. So you made the example of Rhodes University, the University of the Witwatersrand, University of Cape Town. They're all going to be implementing mandatory vaccination policies. But students and staff can choose not to be vaccinated. But if they choose not to be vaccinated, the expectations of them is that they would do everything else that's required of them to minimize the potential of them becoming transmitters of the virus in institutions. And the same thing would apply to workspace. So when someone chooses not to be vaccinated, when there's a company that has a policy of mandatory vaccination, those individuals shouldn't expect, as an example, to be allowed without a mask in common social spaces. They certainly shouldn't be allowed to, or they shouldn't expect to be allowed not to come to work when there is a resurgence because they're afraid of being infected with the virus. Those sort of choices, those sort of options don't become available to you. So yes, there should be freedom of choice. But I think our society is riddled with us living by rules, and that's what makes up society. A society is based on a shared set of values and principles that we all abide to. We don't get into a car if we have had a lot of alcohol to drink and smash into someone else and tell that person that it was our right to get into this car whilst we were intoxicated. There's rules that guard against that. And COVID-19 and vaccination against COVID-19 is no different. So yes, there should be right to choice, but at the same time, all choices come with consequences.
And should vaccination passports be obligatory?
Well, certainly if you want to engage in certain sort of activities, if you want to engage in activities where people are going to be gathering indoors, that's good compelling reason. What we understand of the virus, almost 2 years later, is that 80% of infections that take place because of indoor gatherings, either directly or indirectly. So if people are wanting to go into indoor gatherings, be it a restaurant, be it a shopping mall, be it a classroom, and if they can't show vaccination status, they should be prohibited from doing so because they pose a risk to other individuals that might have been vaccinated, but who might not derive the full benefit of vaccine because they might have an underlying medical condition. So there might be a 60-year-old that has been fully vaccinated, has done the responsible thing, but they don't have 100% protection against severe disease because of an underlying medical condition. They can be expected now to put themselves at risk when they go into a space where an unvaccinated individual might come and is more likely to transmit the virus than vaccinated individuals would be.
Dr. Mehta, what's your view on this?
Yeah, that's a very interesting question, and it's very nice to hear Professor Mahdi's view on it, because this is something that I've experienced throughout my my work. In my opinion, although I think it should be a balance between the carrot and the stick, because seeing the initial resistance towards the vaccine, people were most concerned about this vaccine is very new, the safety profile is not really established yet. So we tended to use a stick, as in for the health workers, because it was easy to enforce in a hospital setting that you need to get the vaccine because you are a health worker. But then what we also observed was that there was a sort of resistance to it. And furthermore, I believe that that is something that is not really enforceable in the community at large. So, but instead of the carrot as well, I think people need to understand the negative externalities of their choices, what Professor Mahdi was mentioning, as in they need to be educated, and they need to be, the message need to be strong, as in what are the consequences of your choices going to be. This sort of goes back to the health belief model I was talking about. People believe that the perceived severity is very less because because they're young, or they're not very susceptible to the disease, so they might as well not take the vaccine. But the communication aspect of COVID vaccine should also include that what are the negative externalities and the consequences to the community could be of their choices and their decisions. And I'm not really in favor of the carrot totally, but I think when people have more information and when they sort of internalize the decision, that is when the message really percolates to the community. Whereas if we tend to go with the stick, it only is limited, that is going to be only limited to the segment of the population where that is enforceable, which I don't believe is enforceable at the larger community. So, but yeah, diplomatically speaking, it should be a balance of two, given the context that we are in. Also, I do believe that vaccine passports are a great way to enforce that, because humans, people in general, like to travel, like to socialize, do activities. So one, it is based on science. Evidence, as Professor Mahdi said, that if someone's going to indulge in activities which involve socializing, then you don't really know that the person who you're talking to or interacting with is an elderly or has a comorbid condition, the vaccination status, so on and so forth. So it's a rational choice, and at the same time a very positive incentive for one to go and get vaccinated. Yeah.
Thank you. Mr. Mutoti, you want to add something to that?
Thank you, Stephen. And indeed, the stick or carrot, but suppose a combination of both should work. And I think the issue that my colleagues have already highlighted, especially with the stick one, if you consider that the Kamusi would love to go to the stadium, and if you go with the approach of the stick and the vaccine passport, that means all people who are going to the stadium will be monitored, and you probably will be aware of the number and the people who are coming to the stadium and how many are vaccinated. If there's a way to isolate those who are not vaccinated, and probably isolate them and put on a different stand, I suppose that will be a measure that will work. But there's a need for the policy makers. If you are going the mandatory route, there's a need for us to draft the policy that are really informed by the experts on the subject, so that our policies are really informed, and the relevant consequences are clearly formulated, so that the population and the community are really aware of the consequences of the choices they are going to make. But whether I'm in favor of the passports or not, I think I'm swayed a bit towards the passport, because who still wants to go to the stadium and enjoy our football? And I suppose the vaccine passport is going to make that possible. Thank you, Stephen.
Thank you so much. I've got several questions already that have come in from viewers, but I want to ask this first one because it's directly relevant to the National Arts Festival and to Scifest Africa. So it's, if you'll excuse me, let me just read this one to you. The National Arts Festival is one of the country's largest festivals. Our format is a little unusual, though. Our festival is large but dispersed over the entire city of Makanda, using as many as 60 venues over 11 days. Our public access mandate is a critical one. The festival provides opportunities for participation for many who would not ordinarily be able to also build our future audience. Like many large events, we have some big decisions to make about vaccinations. Given how sensitive the issues are, is there any advice or experience that the panel can share? Professor Madia, would you like to kick off on that? I'm sure you have some advice on that.
Sure, and I think, like you mentioned, it does speak to the discussion we've just been having in terms of the case for mandated vaccination. But I think it's also important for us to start reflecting on the lessons that have been learned over the past almost 2 years. And as I mentioned, what we do understand of this virus is that the chances of transmitting the virus when you're in a well-ventilated space, especially outdoors, but also indoors, is very, very low. You're not going to get super spreader events when there's good ventilation. And ventilation is key to minimizing the risk of transmission, both in vaccinated as well as unvaccinated individuals. So if you are having these activities, the focus should be to ensure that you've got a safe environment. And for me, there are two important aspects to that safe environment. The first part of it is to ensure good ventilation and to stop engaging in what they call COVID theater. So in this day and age, to be doing superficial thermal screening and to be doing hand sanitization, that is pretty much COVID theater. It actually detracts from what is really required. And what is really required to minimize infections is good ventilation. So that's the first part. And you can have a large crowd. You can have a complete soccer stadium that's full, as currently is happening in the United Kingdom every weekend. With the soccer stadiums, you can get 60,000 people, but you're not going to get a large number of infections because there's good ventilation. In addition to which, the majority of individuals, if not everyone that's attending those sort of events, are vaccinated. So those two things put together, ensuring people are vaccinated, coupled with good ventilation, allows you essentially to get back to a relatively normal lifestyle. And we don't need to wait for a pandemic to be over to get back to a relatively normal lifestyle. We can get back to that relatively normal lifestyle, even in countries such as South Africa, as early as the first quarter of next year, provided that we've got 90% of people that are most likely to end up in hospital and die vaccinated, and the large other majority of the population also vaccinated.
Thank you very much. Mr. Motsoti, you wanted to add to that?
Yeah, thanks, Stephen. There's also another angle. You know, this is just something that need to be considered when the decision is being taken. The assessment of the healthcare system when you want to host large events like this. Should you come back with the so many people exposed and so much infections? Is the health system going to be able to to manage these issues and these severe cases that you would have as a result of the exposure? And I think this is something else that will need to be considered. And of course, this will also guide the decision maker into taking a decisions on whether we should quickly go for vaccination, as this will also have an impact on the healthcare system and the facility that they have. Thanks, Stephen.
Thank you. Dr. Meto, you want to add to that?
Yeah, so about the events, I can share some experiences from the UK where I'm currently based. they have this QR codes at the locations which are frequently visited. And it's sort of considered a citizen responsibility to scan it. What it essentially does, it says that on the NHS app that you were here, which is also linked to your vaccination status. So if you were to be exposed, then it sort of creates a trail where tracing becomes really easy. And I think trace, test, and isolate, which was the initial mantra of the control of this pandemic, still sort of holds. And it's not only about one or the other strategy, just because we are so much down in the pandemic after like so many months. It's still, all the different strategies are still very relevant. Vaccination to begin with, then tracing and testing and isolating in case it is needed. And then, of course, as Mr. Mutoti said, that if such an event is to be organized or is being organized, or we are at such a stage of the pandemic where such events are happening, then you should have a backing up of the health system, as in if we have like upsurge in patients, that we should be able to deal with it. So I think it's a collection of all these interventions which should be still practiced rather than just banking on just the vaccination. Also, something that is practiced here in the UK is if you were to go into a university or a gym or anything indoors, everything is open essentially, but you need to show a lateral flow test, which should not be more than 4 days. So it sort of acts as a self-screening and sort of complements all the other efforts which the government are taking. Yeah.
Thank you very much. There are still so many questions to answer and talk about, but unfortunately time demands that this wraps up our discussion for today. Thank you for tuning in, and thank you to our panel, Professor Shabir Mahdi, Mr. Kamusi Mutoti, and Dr. Amit Maeto. This has been a Scifest Africa webinar, and you can find a recording of this and other fascinating webinars online at the Scifest Africa website and Facebook page. Remember to look out for more exciting Scifest Africa webinars where you can expand your horizons. From me, Stephen Lang, thank you for tuning in, and all the best till the next time.
Thanks, everyone.